Good evening, everybody. Thanks very much for joining us tonight on this Orthopaedic Research UK webinar. It's an update on Clubfoot. I don't know about so much an update, but it's going to be a discussion of Clubfoot in general. We have two presentations for you. I'm going to give one, but the first is going to be given by my friend and colleague, Denise Watson-Tann. Denise is a physiotherapist of much experience. She works at the Chelsea and Westminster Hospital and was very much a pioneer of the extended role in physiotherapy, paediatric physiotherapy for orthopedics generally, but has become increasingly known as a clubfoot expert. But that's not the only area of expertise she has. So her name was first on the team sheet as soon as I knew this webinar was happening. So Denise, it's fantastic to have you along. It's a real honor for me to be on the podium with you once again. We've done it a few times and it's great to have you. So I don't want to take up too much time before we get started. Just one thing to the audience: if you have questions, which I hope you will, because we're going to have some time for discussion at the end, please write your questions down on a piece of paper, and put them in the chat function in Zoom, but please leave that until after the presentations are done. The reason is if you do it earlier than that, they pop up and audiences have previously said that can be a bit distracting. So please keep your questions. And then when we get to the end of the presentations, then put them in the chat box and we'll try and get through as many as we can. Okay, so great. I think that's all from me. Denise, I'm going to hand over to you. And then after your presentation's done, I'll follow you.
Oh, thanks, Gavin. I was really thrilled to be asked to do this, actually, to celebrate World Clubfoot Day. I mean, people who know me know that I am a little bit of a clubfoot nerd. So it's a delight to be here. And I'm just going to make sure we've got the screen. Okay.
Lovely, I can see that perfectly.
Lovely. All right. So I thought we'd talk about a 20-year perspective, my 20-year plus. So I've been doing Ponseti method for more than 20 years, about 22 years. And I thought this first slide, 1985 is when I qualified. And things have changed a little bit since qualification, luckily, and you can see this is what the treatment entailed at the time that I qualified and first started treating clubfoot. And the top two slides you can see here with these little feet is Robert Jones strapping, and the other one is a sort of strap and buckle method of treating clubfoot. Both of these were performed by physiotherapists, but following kite method, and this was a different way of manipulating the foot. The gory surgical slide is pretty standard. So that was postural medial release. So after you've done strap and buckle or kite method, Robert Jones strapping, most of the feet still needed to go to postural medial release. And this, luckily, is a surgery that is really not performed very often at all these days, and hopefully never in idiopathic foot. But you can see it's a really extensive release of the soft tissues, and there's a huge list. It's like a sort of a recipe list of things to release. Surgeons used to love it. It's a very anatomical dissection, but it leads to not great long-term outcomes, as you all know. The bracing was a little bit different as well. This was pretty standard, was to have a boot with a metal strut, and it was quite common to see people who'd had clubfoot walking around with one of these calipers. So standard surgery in infancy. So within the first year of life, most children with structural clubfoot would have PMRs, a postural medial release, or maybe just a medial release, or maybe just a posterior release. But they were open soft tissue surgeries, then managed in calipers. And then there was a whole gambit of operations responding to pain and progressive deformity, all terribly clever, all very exciting for surgeons to perform, but unfortunately, very few of them resulted in pain-free functional feet. I'm just having, there we are. Okay, so what we do know is still 80% of people born with clubfoot are in low and middle income countries. And in 1985, I think the treatment available for these sort of feet would have been absolutely minimal. And you can see the gentleman on the left with these ulcers where he's been weight bearing on his feet. And this is a reality of being born in a country. I'm very pleased that this picture is starting to change, and the work of organizations like Global Clubfoot Initiative that support Miracle Feet and Hope Walks and Walk for Life is really changing the picture for these people. So the more I learn about clubfoot, the less I know. And it isn't one condition, is it? And there's a multitude of conditions. So even within the idiopathic group, you can divide the clubfoot into untreated club feet. So those are feet that have never been near any treatment. Treated club feet, that's feet that have been treated with Ponseti method. Recurrent club feet, these are feet that have been treated with Ponseti method, but have probably recurred. Neglected club feet, I mean, we don't really see this in the UK, but this is a foot that's never been treated and the child is over 2 years of age. Complex feet, these are feet that have been treated with something other than Ponseti method. Resistant club feet, feet that just won't improve, and atypical club feet, which are sort of subtype of idiopathic. And then you also have the secondary or syndromic club feet, which are associated with an underlying condition such as spina bifida or arthrogryposis. And you can see this variety here. So the little picture on the top left is a normal idiopathic foot, untreated. Then you've got the atypical foot in the middle. We've got neglected club feet on the right-hand side. We've got in the middle at the bottom arthrogryposis, and on the bottom left, there is a child with recurrent club feet, but they've also got a neuromuscular condition. So, as I say, the more I learn, the less I know. It's a very complex presentation. So this is the man himself. This is Professor Ponseti, actually standing underneath a picture of Professor Ponseti, who was working during the polio pandemic and actually was an expert in scoliosis and particularly in collagen. And he was a very brilliant, thoughtful man. And he unpicked really the conundrum of the subtalar manipulation. So Kite had a go at correcting clubfoot, not quite got it right. Ponseti came along and he through dissections and through looking at anatomy in very much detail, he sort of unpicked the conundrum of the subtalar joint. He understood the properties of collagen. So he understood how slow stretch could actually change the collagen fibers. The crimp in the collagen fibers could be stretched, and that would allow you to get more manipulation week on week. He recognized that it was important to stick to strict principles of treatment. I mean, he tried many different things before he came up with his method, and he went back to this strict principles of treatment. He recognized that it was very safe to do an Achilles tendon tenotomy under local anesthetic, and it was necessary in most cases. He recognized that the bracing was essential, and actually on the back of his audit realized that 2 years wasn't enough, 3 years wasn't enough, and was moving towards 4 and 5 years in his recommendations for bracing. And we now recommend 5 years. He recognized that tibialis anterior was a good surgery if the foot was corrected first. And I put that in, if the foot was corrected first, because doing a tibialis anterior tendon transfer on an uncorrected foot is highly unlikely to give you the results you want. And he realized that the long-term results far exceeded those of children who'd had postural medial releases or other soft tissue releases. So, as I say, we've been using Ponseti method at Chelsea and Westminster for 22 years. We moved to Ponseti treatment in 2001. We used to see about 6 to 10 new babies a year, and now on average we see about 120 children with clubfoot every year. Not all of them are babies, so there are lots of relapses, lots of recurrences, lots of second opinions. It's essentially a physio-led Ponseti service, although a physio-led Ponseti service is only as good as the orthopaedic surgeons you work with. And I can't speak highly enough of my orthopaedic surgery colleagues that allow us to run the service with them. And we have a special interest in failure to progress cases and relapse. So I thought I'd present this little case. So this is a little chap that I actually treated 17 years ago. And it was sort of, so I suppose reasonably early on in our Ponseti journey. These are the feet prior to any treatment. He was only a week of age, 10 days when he presented in our clinic. And we did the standard Ponseti casting. In those days, average number of casts was 4 to 5. These days, our average number of casts is 3 to 4. So I think just with experience and more practice, we've got possibly a little better at the casting. So he was managed in, these are the Markel boots, where we actually used to punch a hole in the back ourselves to be able to see the heels. You can sort of see vaguely on the left foot on that left-hand picture. And he wore these religiously until he was 4, because at that stage we were still saying 4 years of age rather than 5. These are his feet. And this was a picture he sent me a few months ago where he just climbed up to the top of Snowdon. He'd completed a half marathon. He's sporty, he's active, and he's pain-free. And I mean, this is the journey that our children should be having with idiopathic clubfoot, treated early, following the principles and using the bracing. It's not always that simple, is it? And these are some feet that came to us for a second opinion. So this is about 10 years ago. And this baby had treatment somewhere else, had in this picture on the bottom left is in cast post tenotomy. I was just about to take them off. As you can see, I've split the cast on the left leg, and I was just about to take them off, and I thought, ooh, might be useful to take a picture. So the feet almost look as if they're facing backwards. It was pretty marked correction or not correction, and this is what the feet looked like when we took the baby out of the casts. So you can see that the foot slipped. You can see the steri-strip where the tenotomy was, and you can see that horrible transverse crease. Anyway, the message with this is don't panic. Go back to the principles. So we recast. We actually only had to do 2 casts and then tenotomy. So this is the first recast. So I think you can see from this to this, we didn't leave a cast holiday between recasting because this child had a tenotomy. So we wanted to try and see whether we could get away without having to redo the tenotomy. We actually ended up doing another tenotomy because it just didn't seem to be, the calcaneums still were high. And when this little chap first went into his bracing, we modified the angles, started him off at 30, then 40, and then eventually to 60, because we felt he'd been very stretched in those original casts. Okay. Lots of parental education. They were very anxious about things, but you can see that he's looking pretty nice as a baby. And he's looking even nicer at 10 years of age. And at 10 years on, he has got full pain-free function. And the parents have moved to Australia, which is why his back garden looks a little different from his old back garden. But he's running around, playing sport, pain-free, lovely feet. And it's really nice to see that. Okay. So we know that sometimes things don't go to plan. And I mean, this is where it really is time to phone a friend, is what I've put. So I love this slide. This was provided to me by some parents that kept the slides and documented what had happened with their child. And I think you can see casts 1, 2, 3 don't look too bad, but then they started slipping. And the decision was taken to do a tenotomy after cast 5, but then the tenotomy cast slipped. And so another cast was applied, but you can see they've already lost dorsiflexion, and then another slip and more dorsiflexion lost, and then another slip and more dorsiflexion lost. Now, I would suggest that they probably should have phoned the friend at cast 5, because you can see at cast 5 that that foot is not, and certainly at 6, it doesn't look as if there's enough abduction on that foot, and they'd already started slipping. So they probably should have called at cast 5 and maybe asked for a team that had a little bit more experience to help out, because it clearly wasn't an easy leg to treat. So I'd say more than 6 casts, or if something isn't going quite right, so an unusual response to casting, this child had got a bruised leg and a slip. If an additional diagnosis appears likely, well, not in this child's case, but often you're looking at that. And I've put anything you're not certain about. So also not tolerating bracing. If the child really isn't tolerating bracing and you don't think it's anything that you can't think why that would be, it's worth phoning a friend. This is a really common thing that gets referred to us. So not tolerating the bracing. So this little child came to us because the local team just couldn't get the boots to stay on and they kept slipping. In fact, what happened was that the parents went onto a Facebook group, were told by the other parents on the Facebook group that things didn't look right. So they went to the local team, and the local team were very open and said, okay, well, look, let's see what they think at Chelsea and Westminster. So they sent this foot to us, but you can see it's looking like a rocker bottom. They're not able to get the heel fully down into the boots, and the child was slipping all the time. And if you look at where that tenotomy scar is in the middle picture, it's really low. It's right into the crease. And actually above that was a tight Achilles tendon. So my suspicion is that the tenotomy had been done a little low, maybe hadn't gone through the tendon fully, and certainly hadn't released the heel. Now, it's not necessary to do an X-ray when you see a foot like that, because you can do it on palpation. However, it's sometimes reassuring to do an X-ray, and you can see on the right-hand side that's what you're going to see. If you do an X-ray on a foot like that, that's the sort of picture you'll see. So you can see that the calcaneum is lifted up. It's in parallel with the talus, whereas it should be at 45 degrees. And you can see there's a huge fat pad. So this is a case where a redo tenotomy is needed. So we did one cast, got the foot into a position that we liked, then redid the tenotomy, back into the cast for 2.5 to 3 weeks, and then into the boots. And you might start the boots off again at a slightly shallower angle because you don't want to overstress the midfoot. Okay. So not all Ponseti cases are the same, and some cases are very challenging. And I'm very grateful to this little boy's family for allowing me to share these pictures. So this little chap was born, had a pretty difficult delivery, and the local team referred up to us when he was about 2 weeks old. Actually, he actually needed very little support in NICU. And as you can see, he's got a very severe form of arthrogryposis. Now, we sent him off and did lots and lots of stretching, and then we started the casting. And I think it just shows you what a powerful tool the casting is, because that middle picture at the top is the casting pre-tenotomy. And we were using it to try and get some stretch on the feet, the knees, and the hips. And we actually got him top right into CAFOs, standing as a small child. But then children grow. And actually, he then needed some surgery on some soft tissue release on his hips, which was quite a big deal for him to go through. He's going to be a tall chap. So although we've still got him in CAFOs, at the moment, he's got quite a lot of fixed flexion at his knees. He's very comfortable sitting in his wheelchair. He's doing some standing in CAFOs, but the decision is if we try and do some surgery on his knees, he might not then be so good in sitting. So it's a balance between his function. And that's why I say mid and long-term goals are important, and managing parental expectations. We've always been very open with the family that although he was standing at the top right here, that might not be a long-term thing, but and also we might need to recast his feet. Actually, his feet have stayed pretty good. It's really knees and hips that are more of an issue, but he's ongoing management with somebody like this little chap. So I wanted to share a relapse case study with you. I've had a really big learning curve on this little boy, and yeah, he's been a very interesting child to treat. So he was sent to us with a diagnosis of bilateral clubfoot, and at the time he hadn't been diagnosed with autism. His parents' first child, no positive family history, and no postnatal complications. and he had his initial treatment at his local centre. He had several cast slips. He went through 2 tenotomies at 2 months and 7 months, but the bracing was never established. So they, for one reason or another, they never managed to get him into bracing. So at 2 years of age, the local team asked us to see him at Chelsea and Westminster. So off we went. It was September 2020, and we were very, very enthusiastic. So we did 5 casts, and we listed him for Achilles tendon tenotomies under GA, and then his op was cancelled because of COVID. Parents couldn't get to the hospital because they couldn't drive. It was a long, long journey. They couldn't isolate in order to come. So we had a multidisciplinary team meeting, and we decided we would leave him and see him again once we were able. So roll forward a whole year to November 2021. Lots of other features happening. So by this stage, this little chap is 3.5 years of age, and we've got a different option ahead of us. So what we decided to do then was go straight to tibialis anterior tendon transfer. So recast him, get the foot corrected, then do tibialis anterior tendon transfers plus tenotomies. And by this stage, he'd had a diagnosis of autism. He'd started at a very supportive nursery, and he had much more support in place to manage him. And almost certainly one of the reasons why he didn't go into the foot abduction brace originally was to do with his diagnosis of autism. Anyway, so off we went, started recasting, and did 6 weeks of casting in above knee casts. And then he had a tibialis anterior tendon transfer, 5 weeks of casting in above knee casts. Then we kept him in for a full 6 weeks because we were worried about doing a change of cast on him. And then we cast him for AFOs. And you can see in the picture here, with the bigger children, tend to cast them using a cast box. It's not to push down on their feet. It's to support my hands, which are getting a bit old and creaky. And it just meant he can sit up and watch us while he's casting, and he feels a bit more secure. So that's why his feet are resting on that box. We don't use the box as any part of the manipulation. So this is him. This is him 3 months post-TAT in AFOs walking, massively asymmetrical gait. So when I saw this, I thought, oh my goodness, what are we going to do about this? You know, this is not quite, he's walking independently, quite happy, but he's very asymmetrical. And if I just go back again, actually I'll go forward, you can see that the foot that is really turned out was actually the better foot in the original picture. If I just quickly squeeze back to the original picture, you can see that the left foot was actually much less affected than the right foot. So it's really unusual to see such an asymmetrical gait. Okay, this was him in standing. So we decided not to do anything. We decided to watch and wait. It would have been very easy to jump in and do some more surgery. He's got a lot of cavus on the left side. But anyway, we decided to actually give him some more time out of orthotics and see what would happen. So he had a sort of half and half. Anyway, he then came back age 5. So this is 16 months post-TAT. And he's not wanting to be in his AFOs. And you can see he's much less asymmetrical. Still, probably the slightly worse foot is his left foot, which was the better foot originally. So actually what we're going to do with him is we're going to recast him for a couple of weeks just to improve. I'll just run that video again, actually. Sorry. Oh, this is him in his shoes. Quite interesting. So we're going to recast him just to get a little bit more range on both feet. And that will help him in shoes. This is him walking in shoes. You can see I've got some little 6mm heel lifts in there, but basically out of AFOs, this is what he wants to be. And his gait is so much steadier. He's about to start he's now at full-time school. So if we have to do any surgery, it's going to be a long time before we consider that, because one of the things I have learned about tendon transfer is that it takes a long, long time to see the end results. So I need to speed up a bit. We've had some great initiatives in the UK. The Biscos Clubfoot consensus, if you haven't seen that, it's great. It's really good to give to your managers to make sure you have enough staff, space and equipment in clinic. You've also got the GERFT, getting it right first time guidelines. Point 14, this is for paediatric orthopedics, standardization of clubfoot care, and that things like perform Achilles tendon tenotomy in primary club feet and in infants under 6 months in clinic under local anaesthetic. Don't need to be doing them under general. And D, seek second opinion before significant clubfoot release surgery. And that is for immediate action. So soft tissue surgery should be a last resort. Okay, we've also got great training available in the UK, global clubfoot training. I hope most people know about. You can find that on globalclubfoot.org/training, 12 CPD points. It's a really good training course, and anybody starting out in Ponseti and then wanting to develop their skills. And in fact, there's going to be a further level than that in that there's a conference in Manchester in October, which is also on the Global Clubfoot website. And that's going to be looking at more progression in clubfoot. So what I've learned in 20 years of Ponseti, well, quite more than these things, I hope. But number one is stick to the principles. Actually, what the method that Professor Ponseti first described seems to work. And if you try and cut corners, it doesn't. So papers like doing early tenotomies and changing the order in which you do the manipulation. Why do you need to do that? We know that the original method works well. It's really important to have attention to detail. And I think being slightly OCD helps, being a bit obsessive about the casts. And definitely, if you're not 100% happy with the cast, take it off, because that's bound to be the one that slips if you think it's just about okay. It's really annoying for everybody in the room when you have to replace a cast that you've just put on, but it's much better for the baby in the long run. Families really are the key to success. I think I've shown you in that really complex case, there's no harm in trying in complex feet. You don't know how you're going to get on, however old the person is. And Monica Negura in Brazil presents some work on 30-year-olds who've had clubfoot Ponseti manipulation and treatment, which are just amazing results, things that you would never imagine. MDT working is essential. It really is. Having a great mentor is essential. I'm so lucky to have had Naomi Davis as my mentor, and also the two orthopaedic surgeons that I started with, Alison Hume and Stuart Evans. They've been unbelievably supportive, and a whole multitude of other people that it would take me too long to name. And the other thing I've learned is if you support your team, they'll support you. And, you really, Ponseti isn't something that can be done by one person. And one of the things I love about it is the whole team approach that you need to have to get good results. And I just thought, hot off the press, I'd just share a couple of pictures with you of a great day that we had on Saturday at Chelsea Football Club. And the little guy that's just about to have a goal is 6 weeks out of cast following bilateral tendon transfers. So yeah, I probably would have liked him to do slightly less than he did on the day, but you can see, these kids are just brilliant. And it was so lovely seeing 150 odd kids running around, playing football and not stopping for hours. We were exhausted and they still wanted to go on. So thanks, Gavin.
Brilliant, Denise. Thank you so much for that. So that has hopefully got the ball rolling, whetted your appetite for the second part of the talk. The chat function, by the way, is disabled at the moment. We've had a few bots trying to sell us various bits of software over the chat, but we're going to get that back up and running again for you to ask your questions after my presentation. So let me get underway with that. Let's get going. Here we go. Okay, so Denise has explained about the journey that Ponseti took everybody on. It took him 45 years or more to get his principles established, because my surgical ancestors were obsessed with operating on feet. We loved doing it, as Denise has pointed out. It was a great fun operation for us. but the results were generally disappointing. Ponseti, if we're honest, Ponseti came along and it took him a while, but he completely changed the face of clubfoot treatment. Denise showed some pictures of kids hiking up Snowdon, completing half marathons. None of our kids were doing that before Ponseti came along. So I titled the surgeon, titled the talk, "What's the surgeon for then?" So what am I doing here exactly? Well, I'll come to that, but first of all, back to Ponseti. It is impossible to overstate his contribution. He did, as Denise said, really explain to us what the subtalar joint was all about, and that is key to understanding how Ponseti manipulation works. Now, you can just learn Ponseti technique parrot fashion and not really understand what it is and how it works. It will be effective in your hands if you follow the rules, but it is nothing short of beautiful what Ponseti worked out in terms of the pathology, the pathoanatomy of clubfoot. And as Denise mentioned, he learned this through dissections. He was privileged to have access to such surgical specimens. They're not very common, certainly not nowadays. So the photograph you can see there on my slide is one of Ponseti's from one of his original publications. So there's a lot we still don't understand about this common congenital abnormality, the commonest that we see. We know that family history is important, so presumably there's some polygenetic effect which is causing this deformity to happen, but we don't really know what the underlying cause is. But what Ponseti brought to the table was that he understood that it's the relationship between the talus and the navicular, or in fact the talus and the whole of the rest of the foot, that was so important. So this talonavicular displacement. And there is a term which I don't think was around, or wasn't coined by Ponseti. I think it was coined by somebody else. Denise will correct me if I'm wrong. But this concept of the acetabulum pedis. So what's that all about? Well, if I highlight there the talar head for you, and I highlight there the acetabulum, sorry, the navicular for you, and turn it upside down, you might imagine this looks a little bit like a femoral head and a very dysplastic looking acetabulum. So that's the concept. That's what Ponseti brought to the table. He understood that, I suppose, in contrast to a hip, it's the acetabulum moving around the head. But he understood that the talus has no muscle attachments. And he talked about the calcaneal pedis block, something that you would move around the head of the talus. So this was a really important contribution. And it was from that he developed his method. A couple of other things about clubfoot. One, it doesn't get better by itself. And two, even with Ponseti's wonderful treatment, you can never make these feet normal. So what this means is we're dealing here not with a packaging disorder, like a lot of childhood disorders get better by themselves and become normal by themselves. And we spend a lot of the time reassuring parents that that is the case. But with clubfoot, that is not the case. This is a true dysplasia, an abnormality of growth. But the cause, we still don't know. The picture on the right is a typical idiopathic clubfoot. You might say, well, that's obvious. We all know what those look like. But I suppose one of the role that we doctors have is sometimes in making the diagnosis clear or clearer when there is some doubt about it. So as Denise has pointed out, not all club feet are idiopathic. We may see them associated with neuromuscular conditions, with arthrogryposis or other syndromes. Now, it might not make a difference to the treatment that you institute, but it probably will make a big difference to the prognosis. Then there are two other conditions which are not clubfoot, but might look a bit like it, metatarsus adductus being one example. Here, the hindfoot is normal. And we all talk about this concept of positional talipes. It doesn't actually appear very much in the orthopedic textbooks, but they mean basically something that looks like a clubfoot, but which cannot be completely corrected passively. So that probably is a packaging disorder. And two other subtypes, which I suppose we should be aware of. Denise mentioned one of them, the complex idiopathic clubfoot, that one with that deep medial crease. Those are quite problematic to treat and require a bit of a modification of the technique. Maybe we can get into that in the Q&A at the end. And I thought I'd probably just mention tibial dysplasia because I've twice seen this in my career. There's a particular type of tibial dysplasia that looks a bit like clubfoot, but it's not going to respond. When you see what the x-ray looks like, you can see that diastasis between the tibia and the fibula. There is basically an absence of an ankle joint here. So you're going to get egg on your face if you try and treat that with Ponseti method. That's going to need a different approach. It's really rare, but I've seen it twice, so it's probably worth mentioning. Okay, so here's the beautiful thing about the Ponseti method. And I wasn't aware actually that he was such an expert on collagen, but it makes perfect sense now. Ponseti knew that biological tissues have this property known as viscoelastic properties. It means that unlike rubber bands, which when you stretch them just go straight back to where they were, you can actually change the length of these tissues if you apply a constant force. And the collagen changes and undergoes this process of creep. And that is the reason why the manipulation is done before you put the cast on. But another viscoelastic property is this time-dependent phenomenon, that of stress relaxation. What that means is if you maintain this change in length that you have just done with your manipulation by putting a cast on and maintaining it at that length, then the force that is trying to return it to its original length gradually diminishes. This is good news for manipulation. The third thing that is probably not so commonly appreciated is that by changing these forces in this way around the cartilage analog of the foot, this affects the growth of the foot. So you can see here in these pictures, these MRI pictures, this is from Alan Demeglio's study, you can see how that orientation of the calcaneocuboid joint has actually changed as the casting has proceeded. And that is due to this Heuter-Volkmann principle, the idea that growth responds to different forces applied on it. So this is all good. This is viscoelastic properties working for you. This is nature on your side. But the reason you need a surgeon, or the reason you need surgery, I should say, is because if you try and apply the same kind of principles to overcome the contracture of the Achilles tendon, then those tissues will deform, creep will happen, stress relaxation will happen, and you'll end up with a rocker bottom foot, exactly as Denise showed you. So that is why you still need surgery to do Achilles tenotomies. I'm choosing my words more carefully. I should be choosing my words more carefully because there are physiotherapists out there in the world, and maybe other practitioners too, who perform Achilles tenotomy. And we could have a debate about whether that is something that should be done. It's certainly not complicated surgery, but any surgeon will tell you we have an almost unlimited ability to cause absolute chaos and pandemonium with scalpels. So yeah, that's maybe something we could debate. But anyway, that's what you need surgery for. So this is all good for improving deformity. And of course, the younger you are, the better it's going to work. But deformity is not the only problem, not just in clubfoot, but in a number of neuromuscular foot conditions. There's also this problem of muscle imbalance. And we think this occurs in, getting on for half of the patients. So look, for example, at this kid. This is a kid who's had bilateral clubfoot treated very nicely by the Ponseti method. Looks pretty good, doesn't it, when he stands? But if you ask him to extend his ankles, you can see there that that's not normal. There is an imbalance in the muscles there. And it kind of stands to reason. This is a child with cerebral palsy. And the primary problem there from an orthopedic point of view is muscle imbalance. And that's just ended up in a very similar kind of deformity to what a club foot is. So these two aspects are really important, deformity and muscle imbalance. And important to mention that if you correct the deformity, that doesn't by itself correct the muscle imbalance. And similarly, you can't correct the muscle imbalance and expect that to correct the structural deformity. That's why Denise was saying Achilles, tibialis anterior transfer is not going to be helpful until you've corrected the deformity itself. So just to sort of whet your appetite a little bit, while we talk about this problem of muscle imbalance and recurrence, I want to show you this video, and we're going to do a poll in a second. I'd like you just to answer the questions for us. Nobody's keeping score. There's probably no right or wrong answers. It's just for a bit of fun, just to wake you up a little bit. So this is a 13-month-old child, just now starting to stand. Left foot is the problem. Left foot is the problem. The parents told us it was complex. I don't know if they really mean a complex idiopathic foot, as Ponseti would have described. Seemed like pretty standard treatment to me. Achilles tenotomy was done, tolerating the foot abduction orthosis, but the parents are worried that he tends to walk on the outside border of his foot. When you examine this child, the foot seems quite flexible. That adduction you can easily push back, and it would appear that he's got a reasonable range of ankle dorsiflexion. So Ruth, could we launch the poll now? And when the poll's on your screen, you might want to just shift the window to the side if you want to see the video, which I'll play again for you.
Okay, just another 10 seconds.
Okay, we're done, Ruth, I think, yes?
Yes.
All right, thanks very much for answering that. So, are you concerned about the left foot? So we've got a 2/3 majority thinks there is some concern about the left foot. Yeah, I think I'd be with the 2/3 there. It certainly doesn't look normal, does it? That adduction and the report from the parents of walking on the outside of the foot, that has got to be a worry. Would you call this recurrence? Now here, the majority of you say no, a slim majority of you. So I'm going to go into this a little bit. The definition, is it recurrence? Is it relapse? Is it residual? What is it? And if I can just drag this down here. Now, so in terms of what you advise the family to do, you're all equally split, basically. Nobody knows quite what to do. I'm not entirely sure if I'm honest either. But one thing I would say, you'll see in a moment when we talk about recurrence. Recurrence tends not to get better by itself. So perhaps we can have a debate about this in the Q&A. I think any of these would probably be reasonable options. The only thing I would say about continuing with follow-up, I'd make that follow-up pretty damn close, because I think you're going to likely see something bad happening before too long. Anyway, let's move on. So this is the other area where surgeons get involved. It's this concept of deformity coming back. So what do we mean? I mean, there are different terms here. The term relapse, to me, that means that the foot was normal, but now the deformity is coming back again. But was this foot ever normal? We don't x-ray them, we don't image them. They might look normal, but it can be very hard to know if that foot really is normal, particularly when judging equinus. That can be quite difficult to be sure of, and the position of the os calcis. So maybe recurrence is a better term. That just means the foot's getting worse again, right? You didn't ever imply that it was normal. And residual deformity, well, that speaks for itself, really, I suppose. It means that you never got it right in the first place. And that could be another reason why the parents think it's coming back. It was always there. It's a bit of a problem when we come to look at the literature about recurrence, because there are lots of definitions, including these three, which would be defined as recurrence and are reported as such. But they all mean different things, right? And there has traditionally been no agreement until the Biscos consensus statement. Denise mentioned this, and Denise was actually on the panel that produced this. So here we have a definition. They went with the term relapse, and they said this is a reappearance of any of the clubfoot deformity elements in a foot that is easily fitted into a abduction orthosis. So, I mean, you might argue about that as a definition, but at least we're all talking about the same thing. So that's the latest way to think about foot deformity coming back. Foot deformity coming back, this is common, right? Ponseti treatment is great, but even in Ponseti's own series, he reported up to 40% of the deformities coming back and requiring some more treatment. That is not considered a disaster. That's considered part of the Ponseti method. Most recent large study I could see, this was published in 2021, similar kind of idea. Around 30% of patients will recur, and they will generally do it early. So median age 20 months. So this is during rapid growth. Kind of makes sense, doesn't it? So this is the reason why we recommend foot abduction orthosis until the age of 5, is because it's that first 4 years when the rate of growth is so high and the recurrence rate is high that we need to be careful. You can still get recurrence after the age of 5, but then you've got to have alarm bells ringing that there could be an underlying etiology here. So the key questions are, how to identify it, and how and when do we treat it? And I'm going to answer those questions in just a second, but here's some principles to think about. I've already mentioned one. Don't ignore recurrence. It won't get better. Clubfoot doesn't get better by itself, and recurrence doesn't either. So this kind of ostrich approach to it is not going to help you. You've got a few aspects to consider here, both the shape of the foot, which you want to improve, and the flexibility of the foot. Both of these you want to obtain or maintain. And this issue of muscle imbalance. And bear in mind that correcting the deformity alone is not going to help you with that. Now, there are surgical options for that. There may be non-surgical options for that, but you've got to think of these two things together. In terms of surgery, capsular surgery, the sort of traditional posteromedial release, we generally consider that bad. Repeat capsular surgery, multiple attempts, very bad. But joint sparing surgery, so things like Achilles tendon lengthening, tibialis anterior transfer, these are generally good options for us. So two groups of children who might get the recurrence. In the very young children, you're likely to find out about it because the parents report they're having absolute hell in getting the foot abduction orthosis on. Now, this can be a very difficult stage for parents anyway, but it's worth considering when you get that call that they're struggling to get the foot abduction orthosis to stay on and the child is objecting, you're hoping that it's going to be a problem with the orthotic, like the size, but more often than not, it's actually a problem with the foot. So that's definitely a red flag to us. Could be something else. You've got to think laterally. Maybe there's something else wrong with the child, reflux, for example. But in the older children, it's going to be a gait anomaly. And, as this little chap very nicely demonstrates, they're often live wires, these kids. And thank goodness for slow-mo function on your phone. And you can get videos where you can see these gait anomalies. So walking on the outside of the foot, callosities on the foot, no heel contact, which he's demonstrating nicely as he just comes to the camera and turns around, and a supinated forefoot. All the parents will just tell you it just looks funny. So now let's think about how do we treat these recurrences. So first, I'm going to divide them into three groups. First of all, those young children, less than 3, casting. Casting is the mainstay for these kids. You may need to consider repeating the Achilles tenotomy. Denise showed us a couple of cases. And of course, in an older child, probably you're going to have to think about doing that under general anesthetics. It's another reason why a surgeon is a useful person to have on your team. And then because of this problem of muscle imbalance, you're probably going to want to continue or to restart the foot abduction orthosis treatment. Now, you'll probably be aware there are some different designs. There's some unilateral sprung-loaded designs, and there's this thing called the Dobbs bar, which supposedly allows kids to be a bit more comfortable. These may be useful things. We don't have the evidence and they're not recommended by the consensus statement, but basically anything's better than no orthosis at all. So they may be something that you would want to consider. Once the children get a little bit older, it's still casting. We're still trying to avoid this posteromedial releases of the past. But again, we may need to consider repeating the Achilles tendon lengthening or tenotomy. Kind of surgeon's choice here. For me, once the tenotomy has been done, that surgical field is now scarred, and there are dangers in sticking scalpels back into that field. So unless you're very, very sure where the tendon is, I have a very low threshold for doing a formal Achilles tendon lengthening, but it's a personal thing. Tibialis anterior transfer, once the deformity has been corrected, usually by casting, this is a great operation. So we're talking here about transferring the whole tendon from the medial cuneiform to the lateral cuneiform, as you can see in this picture. Now, it may be that you would want to include some other surgery as well at this stage. So I've mentioned the Achilles tenotomy. You can, if that does not correct the equinus, then a posterior ankle capsular release might be necessary. And sometimes these kids have fixed cavus, which can also respond to plantar fascia release. Now, I know what you're thinking. You're thinking the thunderbolt's about to come down from heaven and strike me down. Well, okay, I mean, I'll take the criticism, but I think that, a posterior ankle capsular release is not the worst thing in the world and is an acceptable thing to consider. It's a world away from a full posteromedial release, and there are some children who require it. So 3 scenarios in which you might consider this transfer. The classic one is dynamic supination in a nice flexible foot, in which case, knock yourself out, go ahead and do the tibialis anterior transfer. But if there is deformity, you must cast first. You cannot correct the deformity just by transferring the tendon. And if there is mild recurrence of the deformity plus equinus, you must deal with the equinus also. So this is a complete change really from what surgeons used to be doing. Older children, red flag. So they could be idiopathic children recurring, but that is quite unusual. So we do need to consider, are these syndromic children? And essentially what you need to do is consider all the components of the deformity. So that includes equinus, and you want to really be sure, is this true ankle equinus or is there equinus in the midfoot or both? And then all of the different components of the clubfoot deformity, collectively, that is a physiological move towards inversion. So the foot may be adducted, supinated, and have hindfoot varus. You need to work out what all of these deformities are and how correctable they are. There could also be a tibial torsion problem. And then basically you've got to divide it into mild, moderate, or severe forms. So this is the minority of children. It's true to say. Ponseti treatment really has revolutionized the outcome for these kids, but we do sometimes see them. And when that happens, it's still casting. Casting, as Denise said, it's always worth trying. You have nothing to lose. But because the children are now more osseous and less cartilaginous, they have less capacity to remodel their growth. And so surgery is going to be necessary. So, you know, there were some horror pictures of external fixators at the start of Denise's talk. I'm going to show you them too, because I consider this extracapsular surgery. So I'm not talking here about you doing external fixators and osteotomy. I'm talking about using them to stretch soft tissues, essentially. That counts as extracapsular surgery, and I would rather do that than the good old-fashioned alternatives of these extensive releases or even osteotomies and fusions. But it is true that there are some kids out there who do need these old-fashioned operations, but they are the vanishing minority, and they are challenging cases when they come. Okay, time for me to wind up. So we surgeons, we are occasionally useful, both in terms of treating recurrence and reaching diagnoses sometimes. The Ponseti method remains the gold standard, but you can expect recurrence in 30% in the idiopathic group. In the non-idiopathic group, probably bigger than that. Don't ignore it. It won't get better by itself. And recasting, regardless of age, is the mainstay of treating recurrence, but it's most effective in the younger children. If you are going to reach for surgery, extracapsular surgery, we love that. Capsular surgery, sometimes we try and avoid it, but repeating capsular surgery, that just ends up in tears and deformity. So that's all I have to say. We have just a few minutes for questions. So get them into the chat. While you're thinking about that, I just wanted to mention this course to you because it may be interesting. You have presumably come on this webinar because you're interested in kids' feet, and Orthopaedic Research UK have a virtual course coming up. It's actually starting next Monday. It's designed for podiatrists. So if there are podiatrists in the audience, this is for you. But if you're a non-podiatrist, I think you will still find some of these topics useful. You can see here hypermobility, chronic pain in children, pediatric athletes, challenging topics, and a road less traveled. So you can scan the QR code or go on Orthopaedic Research UK's website, and you'll be able to see how to join that. Okay, I'm going to stop sharing now, and let us see if we have any questions. Denise, are you still with us?
Yep.
All righty.
Yep.
Let's have a look. Okay, can I just ask you, Denise, for that kid that I showed in my presentation, would you be worried about a kid like that? You know, the 13-month-old with just slight adduction, slightly on the outside of his foot. How common a scenario is that?
Very common. And the first question I would ask is, are they really using the brace?
Yeah.
That would be my first port of call, would be to look at parental compliance with bracing, but I wouldn't be worried, but I agree with you. I would follow up very closely. I don't think I would have recast that one at that stage, but I suspect they're not in the brace quite as much. It's really, he's not walking yet though. And they do weird things when they're not quite walking, don't they, children?
Yeah, they do. Yeah, normal children do. And you're right. I mean, the brace treatment, the parents, they don't want to disappoint you. So they say, yes, they're wearing the brace every night. I'm never quite sure about that.
If they don't bring the brace to the clinic or the brace looks pristine, it's always a slight red flag.
Yeah.
There's a manky factor.
Exactly.
They should look manky. If they don't look manky, they're probably not being worn.
So there's a question in the chat here about using soft cast instead of plaster of Paris. Any thoughts on that?
So people have tried to look at that. I think the studies that I've seen on soft casts, they tend to do slightly more casts, and the relapse rate is higher. I personally absolutely don't think you can get the right manipulation in the foot in a really tiny baby with a very, very, very straightforward foot, but you can't get the same manipulation and hold it in soft cast as you can in plaster of Paris. We'll quite often reinforce the cast with soft cast, but not use it to do the manipulation. So, and it's more expensive.
Yeah. There's a question about, can you explain the options for tibial torsion? Well, I only know of one, and that's surgery. I'm not sure that there's any non-operative methods of improving tibial torsion, but that's not to say that if you see tibial torsion, it needs operating on. A lot of children have internal tibial torsion and lead very normal lives. Yeah, so surgery is an option, but it's not.
Yeah,
it's not one
I've seen maybe 3 children in the last 22 years who've needed the tibial torsion addressed. Yeah, it would be a very uncommon thing to do, wouldn't it? And there was another question that was about the timing of surgery, if I can find it here. What is the earliest age you can consider tibialis anterior tendon transfer in a child with a flexible foot? I mean, the answer is usually about 3, isn't it? Because you need the cuneiform to be ossified. Otherwise, transferring the tendon could be quite challenging. You need it to be about 1 centimetre, don't you? Ossified and about 1 centimetre so that you can get the drill bit in. Exactly. It's as basic as that, isn't it? Yeah. But it's about 3. But what I would say is, if there's a child that's having a relapse around the age of 5 or 6, which does happen, repeated recasting at that stage is not actually terribly helpful because it masks the problem. It can mask the problem. They'd be better off going for a tib-ant tendon transfer earlier than keep on recasting. Yes, absolutely. Yeah. And that's why you need to work with an orthopaedic surgeon. Absolutely. Agree 100%. There's a question about, can you clarify the difference between complex and atypical? Seems to be used interchangeably by different professionals. So complex idiopathic foot was something that Ponseti described, wasn't it, in the last few years of his career, really? Okay, so the global Clubfoot training has tried to be more consistent with the terminology. So an atypical foot comes under the idiopathic group. A complex foot is a foot that's been treated with any other method other than Ponseti. So that could have been kite maneuver, it could have been surgery, it could have been, any of those things. It's very confusing because complex and atypical are still used interchangeably. I think it would be nice if we had more consistency, but I think that's going to be hard to get across the world. Yeah, atypical feet are complex and complex feet are often atypical. But that's the way that it's described in the global Clubfoot training. That's the way we decided to divide it. Okay, but I mean the complex idiopathic foot that Ponseti described has some very typical features, but my understanding is that you don't always see those features at the first cast. It subsequently becomes apparent. So the atypical foot is described as the one that doesn't respond in the same way to casting. So that's the foot that develops that plantaris and a crossfoot midfoot crease. A crossfoot crease. Yeah. Your thoughts on ADMs, Denise? I did show them in the picture. There isn't evidence. There really isn't the evidence there. We don't know is the answer. Maybe there's a place for them. Certainly, I mean, I've got a few children that have got a limb deficiency on the other side that are in ADMs, because then you don't really have a choice. But there's no good evidence that any of the unilateral bracing options are as effective as the foot abduction brace. And if the foot abduction brace works, why change it? It's about education of the parent and, making sure that the foot's really well corrected before the brace goes on. So if we have a baby going into a brace for the first time in clinic, if we can't fit it easily, we'll put another cast on and wait until we can get it in easily. You can't expect parents to be struggling with the brace, and it takes a lot of support. And that definitely is more of a role of, I would say, a paediatric physio than an orthopaedic surgeon in the main. Yes, I wouldn't argue with you. Time's marching on. We're just past 8. I just want to take one more question because it's an important one, actually. Taking the casts off.
How do you do that? I mean, do you use a plaster saw, or do you get the parents to soak it off, or do you soak them off in clinic? What do you find the most practical?
We don't soak them off anymore because we use specialist e-cast, which you can't soak. We use a plaster saw because it's speedy, but it is very easy to cut the baby's legs. So whoever's taking them off with a plaster saw really needs to be trained. I mean, across the world, it's done differently. When I've been out in Bangladesh, there's a big bucket that gets passed around. The baby gets dunked in the bucket and until the plaster sort of dissolves. I think the most important thing is that the cast is taken off in the clinic, not the day before or hours before, that you're taking it off and having as small a gap as possible between cast removal and new cast on.
Yeah. So the plaster saw is an acceptable thing to do, isn't it? Particularly if you have one of the small ones that don't make such a noise, but you just have to be so damn careful because the casts have to be very closely applied. So as you say, it's very, very easy to cause damage.
The small one actually gets very hot. So actually I prefer the big normal vacuum plaster saw. Some babies actually quite like the white noise, surprisingly.
Yeah.
But you just have to, whoever's taking them off needs to be trained and needs to know that the padding underneath is very, very thin.
Yeah. Yeah.
Our healthcare assistant takes them off in clinic. She's amazing.
Yeah, but it's very experienced. Has done many of them, right? So it doesn't matter who's doing it as long as they know. Yeah, they've got the practice.
Training.
So I think I'm going to get in trouble if we carry on with questions. It's 8:03 according to my computer. So I'm going to draw things to a close to say a massive thank you to Denise. As always, you always deliver the goods. Thank you so much, Denise, for your time. Really, really, really useful to hear your stuff. I enjoyed hearing your stuff and my talk and yours. Kind of, we did actually talk about it beforehand. So I'm glad that they sort of came together. Massive thanks also to the wonderful people at Orthopaedic Research UK, Ruth and Tony, who are in the background there somewhere. They're the guys that organize all this stuff. And of course, many, many, many thanks to all of you who participated. Hope you found that enjoyable. Thanks very much and good night.